Cardiovascular Pathology, Diagnosis of MI with EKG Localization of STEMI. All right, so first and foremost, we have to be able to diagnose MI using two things. The first thing is our EKGs, which we're going to be talking about. And every single time that I say EKG, it's the same thing as ECG, okay? All it is electrocardiogram, okay? So don't get confused. If I say EKG, it just means ECG because it depends on what book you're using. But that's the gold standard. The ECG is the gold standard within the first 6 hours when trying to define if the patient has MI. Now, other things that we can look for are our cardiac troponin levels. Okay, so cardiac troponin, I already described it earlier in the other videos, but troponin is a protein that's found in a lot of the cardiac cells. And so when we have death of those cardiac cells, we lyse the cells, releasing all this protein into the blood. And one of those proteins that we look for is troponin. So it tells us whether we have cardiac death. Okay, and so the troponin levels are going to peak at 24 hours. Okay, and there also is another marker known as CKMB that also peaks, but it's an earlier on peak and it dies off relatively quickly compared to troponin. And the reason that we're going to really use CKMB levels is to help us define whether there has been a reinfarction while the patient's in the hospital. So for example, if the patient had an MI on the first day, and then about like 2 days later, we want to see if the patient had another MI. We can't really check the troponin levels because the troponin levels are still going to be really elevated from that first infarction, right? So we have to check the CKMB levels to help us kind of define whether there has been a reinfarction or not. But that's really all you really need to know for those cardiac proteins. Next is the EKG localization of STEMI. So this is a very, very important aspect of defining what's going on with the patient, especially when you're reading a vignette, because they love to just use all these different types of words in order to help you figure out what's going on. But if you don't know them, then it's very difficult. Okay, so first and foremost, you don't have to know the location. I know that if you want to become a cardiologist, you're probably going to have to know this later on, but the locations of them aren't really as important where you put them on the body, right? We don't care. What I care most about is the leads, okay? What those leads kind of relate to with the artery, like what artery is related to it, and then what location of the infarct is it talking about, okay? So to begin with, V1, V2, V3, and V4 all relate to an infarct within the LAD, okay? That is so important. You have to know that. So V1 through V4, V1, V2, V3, V4 is LAD, okay? V1, V2 is septal, okay, anteroseptal. V3, V4 is anteroapical, okay? Honestly, those don't really matter that much. I'm just saying that for the fullness. But no, V1, V2, V3, V4 is the LAD infarction. That's where there's a blockage, okay? The blockage is in the left anterior descending. You have to know it. Next is V5, V6, 1, and AVL. Okay, so V5, V6, 1, and AVL is LCX. So that means that the left circumflex artery is the infarct location when you have V5, V6 elevation or 1 and AVL. Okay, you have to know that. And lastly, and most importantly, is our inferior, okay, lead, which is 2, 3, and AVF. You have to know this one. This is the one that everyone looks at because we always look for an inferior wall infarction. And this tells us that there's an occlusion at the right coronary artery. Okay? Very important. Very important. So 2, 3 AVF leads are going to be showing our inferior wall location. This is the only part that I actually care about. Inferior is 2, 3 AVF and it's RCA. So the infarct location of this one is very important. Inferior. Inferior is 2, 3 AVF and RCA. And the reason behind this, the reason why it matters is because of the presentation that occurs with an inferior wall myocardial infarction. So when we have an inferior wall myocardial infarction, right, we're going to see a STEMI potentially, if it is a STEMI, in the leads 2, 3, and AVF. So we know that it's going to be the right coronary artery. And for majority of the patients that are going to be coming into your office, that's going to be the dominant coronary artery because it gives off the PDA, right? So if they're right dominant, that's coming off, the PDA is coming right off of the right coronary artery. So it's going to be an inferior wall MI, okay? And so how does a patient present? The patient's going to have increased jugular venous pressure with hypotension, okay, and bradycardia, okay? Bradycardia is a very, very, very important symptom that you're going to see with inferior wall MIs. And the reason behind that you get bradycardia is because we know that the right coronary artery, if dominant, gives off the PDA, okay? And since it's dominant, what does dominant denote to us? It means that it supplies our SA node, right? And so if it supplies that node, that's the heartbeat, right? That's essentially the heartbeat, that SA node. So if we lose blood supply to that area, then we get bradycardia because you no longer have oxygen supply to the area that's actually the pacemaker of the heart. So we get bradycardic patients that have inferior wall MIs that are right-sided, that are right dominant, okay? Very important, because the question that they will ask you is, how do you treat that bradycardia in patients with inferior wall MIs? And the answer will be atropine, okay? So make sure you know this overall. We're going to cover atropine in a later section and what that is. But once again, that's just a specific type of drug. You should know atropine just because of your sketchy. So make sure to watch all the sketchy videos, and that will help you get through it all. But how do you cure a bradycardic patient with a inferior wall infarct? You got to give them atropine. As for our other symptoms, like the increase in JVP, we have to fully understand that. And the reason that occurs is because the RCA, right, which is the location of that infarct, right? We have a blockage of the RCA. That right coronary artery, as we talked about in the anatomy of the cardiovascular system, it supplies the right side of the heart. And so if we have an infarct in the right side of the heart, then we have an inability to pump blood from the right side into the lungs and back into the left side, correct? So since we had that inability, that blood backs up, leading to a backup in the systemic circulation, and you get an increase in your jugular venous pressure. So that's where we see the increase in jugular venous pressure. And another thing that they might like to ask is that nitrates are contraindicated completely in patients with a right ventricular infarct, right? The RCA block with an inferior wall MI. Because once again, as I said, the right coronary artery supplies the right side of the heart. If we drop preload even more by providing a patient with nitrates, then they're going to have severe hypotension. There's no more blood going in to the right side of the heart and throughout the rest side, from the right to the lungs and into the left and throughout the rest of the body. So you've dropped all the blood that's coming back to the heart, which is not good. Okay. So just overall, just so that you understand, that right coronary artery supplies that right side. And so that's why we're going to see those three issues: that increase in jugular venous pressure, the hypotension, and mainly that bradycardia, because on the right side of the heart, what do we know that is there is our SA node and our AV nodes, okay? So we have to make sure that we understand that fully. And just a quick overview, lastly, is the V1, V2, V3, V4 are LAD. V5, V6, 1 AVL is LCX, and the 2, 3 AVF leads are RCA.